Hello, everyone, and welcome to the Safe at School Back to School webinar series, Supporting Student Athletes with Diabetes, presented by your American Diabetes Association. My name is Roxana Hutchcroft, and I am a nurse and certified diabetes care and education specialist at Arkansas Children's Northwest Hospital and Endocrinology and Diabetes Clinic. I've also been a member at the Safe at School working group for the past 2 years, and I'm happy to be co-presenting today with Rebecca Allen, who is the Diabetes Education and Technology Manager with the Harold Hamm Diabetes Center Children's Program, which is located at Oklahoma Children's Hospital Pediatric Diabetes and Endocrinology Clinic in Oklahoma City. She's been with the center since 2007, has been involved with the ADA Safe at School program since 2011. She is a registered dietitian, certified diabetes care and education specialist, board certified in advanced diabetes management, and involved in both clinical care and research support focused on diabetes management education. And at the end of this session, there will be time for questions, so please be sure to type any questions that you have in the chat box. And just a few housekeeping things to get through is that this session will be recorded by the ADA and will be made available online for public access and viewing. And in addition, while the ADA attempts to ensure that all information is accurate and current, this general information about potential legal protections and medical best practices is not a substitute for individualized legal, medical, or other expert advice and assistance. The ADA, its staff, and volunteers do not provide legal or medical representation. For legal advice or representation or medical advice, an independent attorney and or professional healthcare provider should be consulted. Okay, so we're going to jump right into this because we got a bunch of good information to cover. But just to start, I want to thank you all and acknowledge the vital role you can all really play in the health and success of our student athletes by allowing them to really fully participate in all sports and activities. So this workshop is really just designed to help you kind of understand what diabetes is, how it affects the body, and kind of what management looks like for these students. And identify signs and symptoms of hypo and hyperglycemia, which I'll be calling high and low blood sugar or high and low glucose throughout the presentation, and really knowing how to respond to these situations. How to recognize how physical activity impacts blood sugar levels, and apply practical sport-specific strategies to keep these athletes safe and performing at their best. So just some important terms that I'm going to make sure we're all on the same page with is that diabetes is essentially high blood sugar. It's really this condition in which the body does not make or properly use insulin. So that's the problem, right? So insulin is this hormone that is responsible for bringing down blood sugar levels. That's its job. And it does this by kind of moving glucose, or what we call sugar, from the blood into the body cells for energy. And this sugar we get from the carbohydrates that the body, eats. So carbohydrates are the body's preferred fuel for energy. And they are kind of broken down into glucose or sugar by the body. And the insulin is responsible for kind of taking it by the hand, opening the door to the cell, and kind of shoving it in there for fuel and energy. Now, when the body doesn't have enough insulin in it, then it looks for alternate sources of fuel. So it prefers carbs, but if it gets desperate and doesn't have anything else to use for fuel and energy, it turns to fat as fuel. And this really causes a buildup of acids in the bloodstreams called ketones, and can lead to a life-threatening condition called diabetic ketoacidosis, or DKA, if left untreated. All right, so what is diabetes? There's lots of different types of diabetes out there. We're going to focus on the two main types of diabetes, type 1 and type 2. So type 1, the defining characteristic really here is it's an autoimmune condition, right? So meaning that the body has attacked those insulin-producing cells called beta cells that kind of live in the pancreas, and it's destroying them in their ability to make insulin. And this attack is occurring in stages. This is not something that you wake up with overnight. And we can know months and years in advance that you're going to get type 1 by a simple blood test to screen for it. But because the body no longer makes insulin, we have to figure out how to get insulin in the body another way. So we have to exogenously provide it. So that means by giving it through injection or through an insulin pump, or even like inhaled insulin for survival. So type 1s have to have insulin to survive, given to them. And although it can be diagnosed at any age and commonly is diagnosed in adults, it is actually the most common form of diabetes diagnosed in children. And if you kind of put all diabetes, type 1 and type 2 in a bucket, type 1 only represents about 5 to 10% of that population. And the remainder is largely type 2. So type 2 is kind of on the opposite end of the spectrum. So this is where insulin is actually being produced by those beta cells. It's just the body's not able to properly use it. And really the defining characteristic here is what we call insulin resistance. So You'll hear the analogy a lot that insulin is kind of like the key that opens the cell to the doors to supply fuel and energy. But in type 2, you have lots of keys, right? You have lots of insulin because type 2s are actually overproducing insulin in a lot of cases, but they're kind of like going up to that cell and trying to open the door to the cell, but it's like the lock has like bubble gum in it or it's rusted. So it's having a difficult time opening the door to let that sugar in to allow the fuel and energy in. Whereas in type 1, really, they don't have any keys, so they can't open the door at all. So that's kind of the difference if you want to think of the analogy with the key. And whereas type 1s, they require insulin for survival, type 2s, treatment can vary here. They can certainly need insulin, and that's a common misconception that type 2s, once they need insulin, they turn into type 1. Type 2s can need insulin as well, but they also have other treatments that can include like oral medications, these non-insulin injectables that we have, and/or lifestyle modifications, just like diet and exercise. It really just depends on the presentation and progression of the disease. And type 2, unfortunately, it used to be very uncommon in children, but now we're seeing it more and more frequently because it is the most common form of diabetes in adults, but it's the fastest growing form of diabetes in children. And also, unfortunately, it tends to be much more aggressive form of type 2 in children versus adults. All right, so generally, whether an athlete has diabetes or not, the goal is to perform optimally, right? And we know that physical activities have a multitude of benefits and advantages when it comes to living with diabetes. This is things like improved insulin sensitivity, increased cardiovascular and respiratory fitness, improved mood, and reduced stress. All of these important things happen. However, being an athlete with diabetes is not without its challenges, but we know with proper management and accommodations, these students can really excel. And these students do have legal protections to ensure their full and safe inclusion and participation in sports. And Rebecca's going to get a little bit more into the legal aspect, but I do want to ensure that we all know how important it is to have an open and collaborative approach with management. This should really include the athlete, the family, the parent or guardian, the diabetes healthcare team, the school nurse, the coach, and really any other responsible school personnel. And a big part of this communication and what we will frequently be referring to throughout this presentation is called the DMNP, or the Diabetes Medical Management Plan. So this is really the foundation of what needs to happen to keep the student medically safe at school. So this is provided by the healthcare team, and it is going to include things like what their insulin regimen looks like, when to check their blood sugars, what a high blood sugar looks like, what a low blood sugar looks like, and the treatment for it. And also give physical activity, guidelines in there too. And I will say that the Safe at School Working Group has recently updated their sample DMNP, and it can be found at this link. And I really highly encourage everyone to take a look at it because it includes some really good information in there. Okay, so a big part of management and kind of like the cornerstone of managing diabetes and what will be included in this DMNP is glucose monitoring. So glucose can be monitored in a couple different ways. So a blood glucose meter, or BGM, or continuous glucose monitor, CGM. So a blood glucose monitor is probably something you all are very familiar with. It's a little device that, you prick a student's finger, there's a drop of blood on there, and then it sucks it up in the test strip, and it displays a number there of what the blood glucose is at that point in time. They've been around for a while. They're very reliable. There are some variables that can impact it, like if the student's hand is dirty, or if they have, or if it's wet, that can affect readings. So just some kind of things to think of when you are checking with a blood glucose meter. And the other way to monitor glucose is a CGM, or continuous glucose monitor. These have really become standard of care, and you'll probably see them more and more frequently in our students with diabetes. But this device allows continuous measurement through interstitial glucose every 1 to 5 minutes through a sensor that sits on their skin. These sensors can't be removed. They stay on there from 7 to 15 days, depending on the brand. And they are just continuously monitoring the glucose in the interstitial fluid. And that's the most important part to understand there. So the blood glucose meter is reading glucose from a different source than the CGM. So blood glucose meter is reading from the blood, and the CGM is reading from the interstitial glucose. So there is going to be what we refer to as the lag time. So the glucose changes in the blood first, and then kind of filters up that change to the interstitial fluid. So that's when you can really see there's a lag difference there. So it's going to change in the blood first, and then it's going to change in the CGM. So expect a lag time of about 5 to 15 minutes behind a blood glucose. But as I mentioned, there's a multitude of benefits to CGM that can really help our athletes perform. They kind of add this other layer of like supervision on through additional, like, because they can alert an alarm through receivers or smart devices or their phones, and allow remote monitoring by caregivers. So again, just another layer of like support that these students can have. And it's not just about, remote monitoring these or the number, like a blood glucose meter just gives you that number at that specific point in time. CGM is really allowed to tell you the speed and direction of what the blood sugar is doing, which can really be helpful for making decisions when these athletes are, performing. Okay, another big part of the DMNP that's going to be in there is all about insulin, right? The medication. So athletes with type 1 will always need insulin. They need that for survival. But in some cases, type 2 will also require insulin therapy. And insulin can be delivered in a few different ways. So we've got a vial syringe. That one's not seen as commonly, but you certainly will still see it out there. You've got your insulin pens, which is kind of where you dial up the dose and inject manually. And then you've got insulin pumps, which come in a couple different form factors. So they have a tubed version and a tubeless version, also called a patch pump. And they kind of work the same way, though. They have this reservoir of insulin in there that they are just continuously dripping out insulin or delivering insulin in higher dosages through a little cannula that's inserted underneath the skin. And these, like CGMs, these insulin pumps are becoming more and more standard of care because they have this, advantages of being able to like give really teeny tiny doses up to very large doses. And they also have this ability to call what we say automated insulin delivery. So it's technology that has really evolved, but it essentially allows the insulin pump to talk to the CGM, meaning that if the CGM is reading a glucose level that's high or above target, then it's going to start delivering more insulin. And if the CGM is telling it that the blood sugar is actually heading down, or below the threshold we want it, then it starts decreasing or backing off on insulin. So again, you can see really the benefit of how that could really help our athletes stay in target range, because that's what it's all about, right? Like we want our athletes to stay, in their blood sugar to stay in range, because that's when they're going to perform their best. They can't perform their best if their blood sugar is too low or if their blood sugar is too high. So first, we're going to talk about low blood glucose or hypoglycemia. So under 70 is considered hypoglycemia, but every student is going to be very individualized in what is low blood sugar for them, especially during, high levels of activity. Symptoms can range from mild to severe. And again, these will differ between each student. And we should all know like what their signs and symptoms are of low blood sugar, but stuff like shakiness, tingling of the hands or tongue, sweating, mental confusion, irritability, vision changes. These are all things that the student athlete might be experiencing during a low blood glucose. And really the important thing here is like, if you recognize a student is having a low blood glucose or they're complaining that they're having these symptoms, then we're just going to treat immediately. We don't need to verify with a BGM or a CGM. We are just going to assume that is a low blood sugar and treat immediately, because we don't want it to progress even further to something more severe. So mild to moderate hypoglycemia treatment, and again, this will be specified in the DMNP, but if a student is having a mild to moderate hypoglycemia event, we are going to treat with fast acting or rapid acting carbs is what we call them. And again, this is typically anything under 70, but maybe a little bit different based on each student. And the key word there, that it's like fast acting glucose or rapid acting carbs. So this is going to include things that are like glucose tabs, glucose gel, sugar packets, fruit juice, anything that's going to go in there and hit the blood sugar very hard and fast to get it back up into that optimal range. There are lots of different types of carbs out there, like milk, chocolate, potato chips. These things that have proteins and fats have carbs in them, but they are not going to be as effective to get that blood sugar back up into the optimal range. So really, we want to really use pure glucose to do that. And a common thing that you will see is 15 grams and the amount of how much rapid acting carbs you need to be giving to these students. It will be specified in the DMNP, but 15 grams is a very common amount. And then after you give that rapid acting carbs, you're going to recheck in about 15 minutes. So we often call this as the rule of 15, because you're giving 15 grams of carbs and then you're rechecking in 15 minutes. And if it's still below 70, well, then you just repeat it until they're back up into that optimal range. A couple important tips here. Remember with CGMs, I talked about that lag time and how important it was to know about that. Really to avoid any rebound hyperglycemia, if they're wearing a CGM and you're, noticing you treated the first time the low blood sugar because they're less than 70, you go to retreat them, they're still under 70, it may be a good idea to verify that glucose with a finger stick. Because of that lag time that exists, the blood sugar could actually be higher than that already, but the CGM has not caught up yet. So it's always a good idea to verify if before doing a second treatment, if using a CGM, just to ensure that you're not going to overtreat and call rebound hyperglycemia, because that's the opposite of what you want to do. Okay. And then the other tip is with these AID systems, or those automatic insulin delivery systems that you see on insulin pumps. These pumps are very smart. These AID systems are very smart. So they're already predicting that this athlete is going to go low. So they're already trying to cut back that insulin to prevent the low. And because of that, you are oftentimes going to not need as much rapid acting carbs or glucose to treat that low blood sugar. So current recommendations are you may only need about 5 to 10 grams, because if you overtreat, it's going to again cause that rebound hyperglycemia and cause the pump to start dumping in more insulin, when again, that's the opposite of what you wanted to do. So severe hypoglycemia is what mild to moderate can progress to. So that's why we treat immediately if we're noticing any signs or symptoms of moderate or mild hypoglycemia. So severe hypoglycemia is probably one of the most acute concerns that we have for these student athletes, because it can lead to, it can progress very rapidly. And it's not necessarily a number. It's more about the symptoms that are seen. So these symptoms are the inability to eat or drink, if they're unconscious, if they're unresponsive, or if they're having a seizure or convulsion. So if you see this in any of your student athletes with diabetes, then you're just going to act immediately. You're going to give that glucagon and give it as soon as possible. The good news about glucagon is that it's life-saving. You cannot overdose it, and you cannot harm a student by giving it. So what glucagon is this just natural occurring hormone that's made in the pancreas. So, insulin's job is to lower blood sugar. Glucagon's job is to actually raise blood sugar. And it does this because it sends a little signal up to the liver, and our livers are little sugar warehouses, right? That's where we store a lot of our sugar. And the glucagon goes up there and says, hey, liver, we're in trouble, like dump everything you got. So it releases all that sugar into the bloodstream and kind of raises that blood sugar for the athlete. And there are lots of different formulations out there now. They could be administered by injection or by nasal like powder spray. The biggest take-home point I want us all to get from this is that coaches and athletic trainers, or non-medical personnel in general, may be able to be trained on this. We all know that school nurses are the most appropriate person to be providing this care to our student athletes, but we also know that school nurses can't be everywhere all the time. They're often covering multiple schools or taking care of 600 or 700, students, and they can't be at every game, every practice. However, it's still the school's responsibility to ensure that these student athletes still have someone that can respond and recognize an emergency situation like a severe low blood sugar. And it's dependent on state. So I encourage you guys to look at your state and see if you guys are one of the states that are able to be trained as non-medical personnel to administer glucagon, because it can be life-saving. Other couple things to know about glucagon is that it can cause some nausea and vomiting after you get it. So make sure you turn them on their side if you do give it, and then call glucagon or have a second, or call 911 if you have administered glucagon. Is always a good idea. But please check and see if you guys are in a state that does allow for these to be trained for glucagon. And side note, even if they're marked as independent on DMNP, an emergency can happen anytime with these students. So we still need to make sure, even though they're responsible, able to take care of themselves, or independent, that they can still run into an emergency and they would still require outside assistance, and someone still needs to be prepared to and trained on how to give them emergency glucagon. Okay, so we've got Zach here. He's 15. He's had type 1 for 10 years. We're just going to go over an example here. He uses insulin pens or injections, and he uses CGM. And he plays basketball. He's a point guard. And mid-practice, he becomes shaky, pale, seems kind of unexpectedly confused during drills. And unfortunately, Zach left his smart device, which has the CGM readings on it, in the locker room. That means it's out of range. So that's an important point about CGMs to know, is that they talk to each other via Bluetooth. So that sensor that's on the student is sending a Bluetooth signal to the receiver or to the smartphone to give readings. So if it's out of Bluetooth range, you are not going to get a signal and you're not going to get a reading. So that's a side note. But what do Zach's symptoms most likely indicate here? So he's shaky, he's pale, he seems confused. So those are likely causes or symptoms of a low blood sugar. So just some comments here on like how we should react to this is ideally our students always have their CGM in range or they have a BGM to verify. But again, if you are ever seeing a student that is exhibiting symptoms of a low blood sugar, they complaining of symptoms of a low blood sugar, you don't need to verify. You just need to treat because again, you want to prevent it from progressing to something more severe. So for Zach, his DMP will probably say, okay, he needs 15 grams of quick acting carbs or those rapid acting carbs. That could be stuff like juice or glucose tabs or, whatever it is. But it needs to be 15 grams of quick acting, rapid acting carbs. And then he's going to recheck in 15 minutes. But remember, he has a CGM. So if his CGM is picking up at that point, then before you retreat, if needed, then you're going to verify with the finger poke to make sure he's not actually back up at that optimal range to avoid over treatment. And Zach is not using an AID system, but if he was, he may require less fast acting carbs. So he may not need that 15 grams, and that would be kind of specified in the DMP, an appropriate amount of carb to give him. Other important tips is remember remote monitoring is another layer of supervision that we can offer these students. It may require connection to Wi-Fi, and that should be an accommodation that schools provide for them if they need, a stable Wi-Fi connection. Okay, so high blood sugar is our next topic here. So our high blood glucose. So this is the opposite end of the spectrum, really. And anything over 180 is considered like a higher blood sugar. But I will say for most of our student athletes, they may have actually higher targets for that. And that's okay. It's going to be very individualized. But once you start getting like above 250, that's kind of when we think, okay, that's probably not at a level where they're going to be optimally performing. And do we need to check for why and start checking for ketones? But symptoms here can vary, but it's going to look like excessive thirst, dry mouth, that frequent need to go to the bathroom, blurred vision, increased appetite, fatigue, or weakness. Those are kind of like all common symptoms that you may see with high blood sugar. And that 250 level, again, that's kind of when we get most concerned about ketone production, which is, remember, the indication for ketones is like that is telling you that the body is insulin deficient. So frequently you're going to see ketones produced at a higher blood sugar. But just to be clear, you can develop ketones with a lower normal blood sugar as well. But typically they are going to be seen with a higher blood sugar because that's the body telling it that we don't have enough insulin in the body to do what we should do and provide yourself with like fuel and energy. So ketones can be monitored in a couple ways. So you can look at urine ketone testing, which is simply just a color, indication, gives you the level of what the ketones are after you dip it in urine. So those are most widely used, but they're also blood ketone meters, which kind of look like blood glucose meters, but they require like a special meter and a special strip. And it gives a number versus a color. Blood ketone meters are actually a little more accurate and don't have like the lag time that exists with urine ketones, but you won't see them as commonly as you will see urine test strips. Okay, so ADA does have a couple just general recommendations when it comes to hyperglycemia and exercise, is that really if you have moderate to large ketones present, you should avoid exercise in general until the cause is identified and addressed. In addition to that, even if you don't have ketones, if your blood sugar is over 350, then intense physical activity should probably be avoided because it's going to actually exaggerate the hyperglycemia that's already there. And if exercising with ketones, you're probably just going to make the ketones worse, which is kind of why we say don't exercise if you have moderate to large ketones, because we really want to, eliminate that risk for progression into diabetic ketoacidosis or DKA. And just to wrap things up here, you're always going to follow your action steps in accordance with your DMNP, right? So that can be, maybe you need to check verify the CGM with the blood glucose meter check. Maybe you need to allow for hydration and allow them to go to the bathroom frequently and access to water. Maybe they need a corrective dose of insulin. Maybe this is a pattern that you're seeing and you need to notify the parents or the healthcare team to kind of make adjustments to the insulin regimen. But really, like the biggest thing here is that we really want to eliminate barriers to management and avoid judgment based on individual glucose readings. Diabetes is really challenging to manage in general, and that's the key term. You can manage it, but you can't really control it. So sometimes these athletes may not know why their blood sugar is high. Maybe they just had an adrenaline spike. So really avoiding questions like, what did you do? Why is your blood sugar so high? Or some things that you may want to consider like avoiding. But I'm going to turn this over to Rebecca, who's going to talk about our next case scenario, Joey.
Thanks so much, Roxana. For any that may be joining late, my name is Rebecca Allen. This presentation will be made available and you'll find my credentials mentioned at the beginning of the recording. Before discussing Joey here, I'd like to first start with a brief story. Gary Hall Jr. is one of many famous athletes with type 1. Again, this isn't our case and not on this slide. Rather, he's a swimmer who won 10 Olympic medals, including 5 gold in the late 90s and early 2000s. The reason I mention is that his story serves as an impressive reminder that there are many with diabetes participating safely and successfully in all types and levels of athletics. And when he was asked in an interview what advice he had for others, he mentioned 3 things I'd like to share. If you manage your diabetes, you can do anything you put your mind to. 2, taking care of diabetes is not always convenient, but it's worth it. And 3, take advantage of the resources available. And with that, please know that each of you here are an important resource to your athletes and they need your support. Although there's not a one-size-fits-all approach to learn, there are consensus guidelines, and we'll dig into some general concepts next. But first, let's now talk about Joey's case. He's a 10-year-old with type 1 for the last year. He uses an AID system, which recall is a pump that works with his CGM to automate insulin adjustments. He's a catcher for his league's baseball team, and during practice one day, his CGM alerts that he has a high glucose that reads 232. Joey did just eat a granola bar and had milk 30 minutes before practice, and he feels well and he wants to continue. We'll talk now about what is the next best step. And Roxana, if you could go to the next slide, please. So we acknowledge this can be a busy slide, so I'm going to go through some key points pretty slowly. To answer our action correctly, which would be to provide water, keep Joey in practice, and monitor per his diabetes plan, one would really need to understand that insulin works for a duration of time, and sometimes we call this insulin action or insulin on board. Yes, his glucose is considered high, but he just ate and gave insulin only 30 minutes ago. So even though his CGM value will update every few minutes for us, his sensor reading will continue to decrease while the insulin continues to work. So long as Joey doesn't have any concerning signs or symptoms, which weren't mentioned here, there's not any need for him to miss out on practice right now. And so it's important to remember that treatment decisions for hyperglycemia or high glucose should consider the current glucose you're seeing and any possible insulin on board. Also remember, glucose fluctuations are normal and expected. We want to really avoid blaming Joey for the number that we're seeing. He just needs access to water and the bathroom, and it's too soon for additional insulin and unnecessary to pull him out of practice. So instead, we'll let him participate and we'll recheck according to his DMMP. Commonly, you might see this listed as 2 hours after any carbohydrates or rapid-acting insulin. Also not detailed on this slide, but if ever the athlete's symptoms don't match a sensor or a blood glucose reading, then it's recommended to recheck using the finger stick blood glucose. Also, if checking the finger stick, it's critical to have clean hands for an accurate reading. For example, if any food or drink was on the hands, this could falsely result in a high reading and possibly then inappropriate action. So if questionable, using the second drop of blood can help to provide a more accurate result. So let's summarize here on this slide with a few important tips for athletes of all therapy types. Please avoid judgments of any glucose readings. There's not good or bad numbers, it's just information. Also remember, if there's not enough insulin, ketones can build up and result in DKA without intervention. So this might happen with missed insulin with a pump malfunction, missed doses, or if they were disconnected or suspended for too long. So ongoing monitoring is important, and certain high glucose will definitely require immediate attention. Next slide, please. So here you'll see a nice checklist of usual and very necessary supplies. As Roxana mentioned, the DMMP is the document that will specify the student's diabetes needs at school, and this should also include their supply needs. In addition to their usual monitor, they'll need to include backup supplies to allow quick attention and try to be sure that we have what we need to limit missed school or other participation. This also includes blood glucose testing supplies, even for those who are using CGM. And then with technology advances, supplies now more commonly include their smartphone as well. And so if so, this should be exempt from restrictions limiting access to be sure they're not without this critical management tool. You'll see treatment supplies included here in the middle, and we want to be prepared with options to treat any low or high glucose supplies when needed. These include quick-acting options like fruit juice, glucose tabs or gels. Other more complex snacks may also be needed, and we'll get to some of those examples in the coming slides. Glucagon is another recommended supply, and although hopefully rarely used, if ever, it can save their life if needed and should always be on hand. In addition to having their supplies available, they should be stored properly, paying particular attention to any temperature needs, especially if they'll be outside or opportunity for temperatures that may compromise their effectiveness. Next slide, please. So now let's talk about plans. Before discussing details on this slide, we should mention that educational plans such as a 504 plan or an individualized education plan would include many additional details not included within the DMMP Roxana discussed. Examples may include before and after school, travel, standardized testing, and other unique activities. We sometimes refer to these plans as briefcases because they include the DMMP or provider's orders and many additional details for reference. If the student doesn't have an educational need that would require the special ed instructor, then the 504 plan is generally the plan recommended. These plans would be developed as a team, including the school nurse, the family, and other staff involved. Also included is their individualized healthcare plan, and these plans will elaborate on who does what tasks and where these tasks take place. For those unfamiliar, the Section 504 of the Rehabilitation Act is a federal law that prohibits discrimination on the basis of a disability. As detailed here, this law ensures that students with diabetes can fully participate in all activities. It requires that a school nurse or other trained staff to be available according to their plan, and parental attendance cannot be required as a condition of participation. Staff, including coaches, must be able to recognize and assist with any lows, including glucagon if permitted, and responsible school staff should ensure necessary supplies are always available on site with the physical activity. You can actually find a 504 plan example on ADA's website that's listed here. Next slide, please. So now we'll discuss how physical activity affects glucose levels. Next slide. Clearly, this slide indicates that there are many factors that impact glucose. It's a pretty busy slide, and we'll touch on just a few. Of course, the activity type, the intensity, and the duration will affect glucose, and we'll discuss this a bit more in the coming slides. It's important to remember that there are many factors beyond the physical activity that can also impact glucose, among which include many common biological factors like hormones. But hydration status can also play a role. Specifically, blood glucose appears falsely high with dehydration, and this can negatively affect important treatment decisions. They might also be affected by age, nutrition status, muscle mass, or overall fitness, and in general, the lower the fitness level, the higher the risk for lows. When and what the athlete ate last may also play a role. This includes the meal itself, but also how much insulin they have on board, the type of therapy that they use, and any pump or AID features. As mentioned, we want to consider any last insulin delivery, and we'll discuss for certain activities, it's generally ideal to have less insulin on board during the activity. A last factor we'll mention today includes the environment, such as altitude, cold, heat, or humidity. They may even have higher insulin needs during activities at altitudes greater than 5,000 meters related to altered glucose metabolism. And recall, glucose appears higher with dehydration, and that can often occur with activity. Of course, extreme, prolonged exposure to heat can also cause their insulin to break down and not work properly, contributing to highs. And lastly, it should be mentioned that insulin works faster when there's increased blood flow, as would happen with heat or altitude, and also works faster with increased absorption, like during exercise, heat, or massage. It's even recommended that insulin be given in an area that's not actively engaged in muscle contraction to help limit this risk for lows. Next slide, please. There has been extensive physical activity guidelines written for children and adolescents with diabetes, but again, no approach that's recommended for all. We just saw and discussed many factors that affect glucose, and to complicate things further, these variables can affect people differently. And so the approach to care must be individualized for each athlete. Also, different types of activity have different effects. Specifically, you'll see on the right side of the slide, aerobic activities like walking, running, jogging, swimming, and biking tend to lower the glucose, and I usually find that folks are more familiar with this particular trend. However, as you'll see on the left of the slide, anaerobic activities like sprinting, weightlifting, high-intensity interval training, or certain competitive sports are actually more common to find a rise in glucose instead. And so you might find high glucose during these event types. Unlike someone without diabetes, these athletes are not able to automatically regulate their insulin to the changing needs of the various activities. And although not mentioned as often, their body's natural glucagon response may also be impaired, making glucose management even more challenging for them. Next slide. Here you'll see basic steps to glucose monitoring with physical activity include: first, know the target range per their DMMP. Each athlete's target range should be clearly identified in this plan, but general guidance is to begin with a glucose within 126 to 180 for most athletes doing aerobic physical activity lasting up to an hour. Second, check glucose at times specified in their plan. Frequent glucose monitoring before, during, and after the activity are important to prevent, detect, and treat any associated lows or highs. And then third, take necessary action. You'll want to understand when and how to act according to their plan. And these actions must consider the current glucose, their insulin on board, and their management tools, such as whether they use a CGM or an AID. Remember, while monitoring, it's recommended to delay intense exercise if the glucose is above 350, and always check for ketones with an elevated glucose as specified in their plan. It's really important to delay exercise if they have moderate to large ketones, or participation may actually worsen their risk for DKA. Next slide, please. So now let's discuss a few strategies for those activities that present risk for lows. Your athlete may use one or several strategies as detailed in their DMMP or their 504 plan. But first, let's discuss insulin action. Recall, rapid-acting insulin usually peaks at about an hour to 2 hours after dosing and can last in the body up to 5 hours. So what this means is we might consider there to be a high insulin state in the 1 to 3 hours after an insulin dose, or a low insulin state if they're fasting, or 3 or more hours after their last dose. Really, it might be ideal if they could eat 3 to 4 hours before exercise to prevent insulin peaking during that activity. However, we also know this is often unrealistic, and there are other options. Over here on the left, you'll see carbohydrate considerations include using uncovered snacks, meaning without insulin. The timing and the amount will depend on the athlete's unique goals with the activity, and we'll discuss these amounts and recommended food types on the next slides. Another option might include an insulin adjustment. For example, one might include a bolus reduction for a meal or snack if exercise is planned within the next 2 to 3 hours. And similarly, a dose reduction may be necessary if it's less than 2 hours after their participation. And then there's also technology considerations here on the right. Technology now allows more frequent and convenient monitoring for a more proactive approach to prevent glucose extremes. But it's critical that they have access to their technology for those activities. And we'll discuss soon how glucose monitoring can guide plans. But we've already mentioned pump disconnect recommendations to limit risks with missed insulin. So let's discuss some advanced features now. It's really exciting that most AID systems have an exercise feature that when activated might automatically raise their glucose target and make the automated dosing algorithm less aggressive. Ultimately, what this does is decrease their insulin on board to help prevent lows. So for those on pump therapy but not using AID systems, basal rates can be used instead as an option to reduce their insulin on board. Either way, it's recommended to start either exercise feature or temp basal rates 1 to 2 hours in advance of when less insulin on board is actually needed for greatest benefit. However, the timing of these features will vary depending on the athlete's unique trends or needs. Next slide. Here you'll find general glucose goals and pre-activity carbohydrate recommendations, and we'll take a moment to go through these by each glucose range. Recall we discussed general guidance is to begin the activity with a glucose within 126 to 180 for most athletes doing aerobic physical activity lasting up to an hour. So if the glucose is less than 90, we would delay exercise until the glucose is 90 or greater by treating with 10 to 20 grams of quick-acting carbohydrate. Again, these would be options without protein or fat to ensure quickest action. And examples might include half a cup of fruit juice, a cup of sports drink, 3 to 4 glucose tabs, or half a cup of fruit. Whereas if the glucose is within 90 to 125, uncarbohydrates are still needed, but instead only 10 grams of glucose before starting the exercise. And in this particular range, complex carbohydrates with protein may actually work better to prevent lows, since the glucose may not need an immediate or quick rise. Examples for this might include a mini granola bar, or crackers with string cheese, or an apple and peanut butter. Also important, if the athlete is using an AID system that does automated insulin delivery, they may require less carbohydrate, and it's recommended to limit any uncovered carbohydrate sooner than 10 minutes before the activity. As Roxana mentioned, carbohydrates provided too early will lead to a glucose rise, and then that automated system will automatically deliver insulin for that high. And this actually works against any efforts to reduce risk for lows. Now let's look to our last row here on the left. If the glucose is 126 to 180, we'd proceed with the activity without any need for uncovered carb unless the athlete had a higher glucose target in their plan. Keep in mind also that weight training or interval training may not require any additional carbohydrate intake unless they're actually low. Next slide, please. Next, we'll discuss possible carbohydrate needs during the activity. And monitoring is also recommended every 30 minutes throughout. I think we've all likely already experienced that it's sometimes pretty challenging to detect lows or highs from the athlete's symptoms or alone. And for this reason, use of CGM during physical activity is strongly recommended as the preferred option to assist and help to guide preventive strategies with the use of their glucose values and trend arrows. Again, additional carbohydrates without insulin may be necessary to prevent lows, and decisions will still be guided by their unique exercise target. However, during activity, it's recommended to use quick-acting carbohydrates for quick adaptations throughout rather than complex. This would be the time to consider sugar-containing sports drinks or glucose gels to help maintain glucose goals. And if they have higher levels of insulin on board, then even 30 to 60 grams of carbohydrate per hour may be necessary. Although there are recommendations available to guide specific carb amounts, a lot more detailed, these are not necessarily helpful for today's discussion, and so we won't dive into those today, but rather look to your athlete's plan for specific details. More effective options during this time will be found here over on the top left. These would be glucose sources, drinks, or tabs. However, sometimes we have athletes that have other quick-acting preferences that will still work, like fruit juice or candies. As we've mentioned a few times, options with carbs and protein or fat are more slowly absorbed, and so they do have a delayed effect. In addition to these more complex food types generally being less well tolerated during participation, they may actually increase the risk for lows during the activity, along with a delayed effect on the glucose with additional carbohydrates uncovered, causing highs afterward. So rather than providing peanut butter crackers or other complex options throughout, lean towards sports drinks, glucose tabs, or gels throughout to provide an easier way to maintain the glucose and limit their risk for highs later. Next slide. So the athlete has finished the activity. So what's next? Well, there are several nutrition considerations, including meals typically within 90 minutes, depending on their glucose levels. And it's recommended to prioritize including protein source with at least 15 grams or more. Carbohydrates are also important to replenish used stores and to prevent lows later on. Of course, hydration is important before, during, and after, and preferred options may vary depending on the activity type. For example, water is actually the most effective drink for low intensity and short duration sports. Sports beverages can be useful for lows during those activities, but otherwise usually not recommended for these shorter and less intense sessions. Rather, sports drinks would be great for those longer duration activities to provide both fuel and to help meet glucose goals. Meals served with water or milk can also help with hydration. And then, similar to other management plan details, the athlete's portion and nutrition requirements will vary based on multiple factors for that unique athlete. Next slide, please. So next we'll talk about Emily. She's a 13-year-old female with type 1 for the last 3 years. She also uses an AID system and runs cross country 5 days a week for 1 to 2 hours, beginning 2 hours after lunch. She does distance runs 3 to 4 days a week with interval training 1 to 2 days a week. And her CGM alerts that she's low, reading 62 mid-long run. So let's now talk about the next best step. So next slide, please. Again, we'll go through this slowly to catch some important tips. Since Emily's glucose and symptoms indicate she's already low, it's important to stop and treat with rapid-acting carbohydrates immediately to prevent worsening lows or severe symptoms. Planning is critical, and each athlete will need access to all their supplies. Emily requires her AID system, which includes her CGM, her pump, her smartphone, low treatments, and other usual supplies during practice. She wears her system during practice and carries several glucose gel packets in her shorts in case needed. She also uses the exercise feature on her AID system set 1 to 2 hours before distance runs, and she continues this pump setting until practice ends. This is individualized to her trends and can be different for others. Recall, aerobic activity tends to drop the glucose, so we're unsurprised that this occurred with her long run. Her CGM data is incredibly helpful to provide alerts with low glucose predictions, and these allow action ahead of time. Also, we discussed earlier that anaerobic or mixed activities are associated with less of a drop or even a rise in glucose. And in point, Emily often has highs during her interval training, needing different attention. Recall, glucose monitoring may be done more conveniently and with additional trend and remote monitoring opportunity by CGM. So remote monitoring by coaches or other school staff can also provide another layer of supervision, but it should be individualized based on the student's unique needs. So to summarize here, a few general tips for athletes of all types include uncovered snacks without insulin might be considered, but these should be individualized, and generally quick-acting carbs are used when glucose is below target, like sports drinks, while complex carbohydrates with protein, such as a mini granola bar, may help to prevent hypoglycemia throughout the activity. Another consideration includes reducing their insulin dose if it's been less than or more than 2 hours after the activity. And then athletes on insulin pumps and AID may consider activity or exercise mode to reduce their insulin on board and risk for lows. Next slide, please. So to support the athlete with diabetes, we ultimately want to reduce any barriers associated by increasing knowledge for full and safe participation in all activities. We know diabetes management is very complex, and athletes with diabetes may face many hurdles. Remember that you are an important resource available to your athletes. Some accommodations or responsibility that can help support them include glucose monitoring and responding to any lows or highs. Ensure they have access to their supplies. Allow time to test their glucose or treat as needed. And it's really important to have a basic understanding of the athlete's technology and their need for continued access. Becoming familiar with your athlete's 504 plan, their DMMP, or other written plan will help eliminate barriers. And please avoid judgments based on individual readings and continue good communication with the parent and the school nurse. Next slide. Thank you so much for attending today and for your support of athletes with diabetes. Next slide. You will find references used for this presentation here. And again, this presentation will be available for your review later. In addition, please know there are ongoing international collaborations to provide additional resources and usable tools to assist with these challenging needs. Next. We'll skip 2. And next. You may also find additional ADA Safe at School resources on the website here or by calling 1-800-DIABETES for more information. So now I think we will go ahead and take a few questions.
Okay, yes, we have a few questions. The first one is, will the time of day of practice or competition affect the athlete when it comes to glucose levels? Example, early morning workouts versus late afternoon.
Great question. I'm happy to take this one, Roxana, if you like.
Sure.
Yeah.
Go for it.
So as we mentioned, hormones can definitely affect glucose levels, and we can find hormones early in the morning in particular that cause higher glucose values. And so when there are early morning practices, this can definitely affect those glucose readings that you see. Hopefully, with those trends, we can have planned actions to help reduce the risk for those excursions during that time.
And I
Okay.
will just add that it's very common, like we recommend the best time to, be physically active or exercise is when you have as little like insulin on board, we call it, like Rebecca kind of mentioned prior, as possible. So if the student athlete is having problems with lows, oftentimes a good time to have that aerobic kind of exercise is first thing in the morning, because you are more insulin resistant because of those hormones in the morning. And it can be more challenging in the afternoon when you're post lunch and dealing with insulin boluses that have been given. So that may be another, like, just nugget of information, that sometimes it's easier to actually exercise in the morning and in a fasting state. So you're not dealing with that insulin on board.
Absolutely.
Okay, next question. Should schools make sure a school nurse or other school staff member has been trained to give glucagon during games, practices, or trips?
Yes. You want me to take this one, Rebecca?
Sure. Yeah.
Yes. So like kind of I mentioned earlier, it is the school's responsibility to make sure that that in an emergency situation, even if the student is marked as independent, they have someone that can recognize and treat severe hypoglycemia. And in most states, that doesn't have to be a nurse. It really just depends on the state regulations, but absolutely there should always be someone there that knows how to recognize and treat a severe low blood sugar, games, practices, any school related event.
Okay. Can students with diabetes still participate in practice or a game if their blood sugar is high?
Roxana, you had a case with this as well. Do you want to take this
Yeah,
one?
sure. So absolutely. I mean, I think it depends on, there's some variables in there that, may affect this, but in general, you may have to look at other situations, like do they have ketones present? Like how high is too high? Like, right, we talked about the greater than 350. You may want to postpone if it's that. Or if you have moderate to large ketones, then you may want to postpone exercise or activities because of that. But in general, a student should not be, automatically, not allowed to participate just based on one glucose value. There's other variables that you need to look at to ensure that they're safe participating, but it doesn't automatically eliminate them from participating just because they are have a high blood sugar level.
Okay. Nasal spray versus glucagon injection. What do you think?
Yes. I mean,
Yeah, I think it's great that we have multiple formulations now. We aren't brand specific, but we want something that is as simple and less intimidating as possible so that individuals aren't hesitant to use a glucagon formulation whenever it's necessary. Unfortunately, sometimes insurance dictates which formulation that the individual is able to have on hand. And so just kind of be aware that if you have one formulation over the other, it may not actually be at the decision of the athlete that you have.
Okay. Is finger stick blood glucose or CGM more accurate?
So really good question. I feel like this is a question we discuss a lot, but remember they're reading two different sources. So it's not about which one is more accurate, I would say, but it's more accurate. The blood glucose meter is going to be accurate in that moment because remember the glucose changes in the blood first, and then it's kind of filtered up to that change to register in the CGM. So there's that lag time that we kind of talked about earlier. So the here and now and most present is going to be the blood glucose meter, but CGMs are still highly accurate and reliable, but there is that lag time that's going to exist, and that lag time could be affected by these athletes that maybe are very active, or if they're dehydrated, those can kind of impact what you see in that lag time on the CGM as well. So yes, I would say blood glucose meter is going to show you the most accurate in that moment what the blood sugar is doing.
I would echo what Roxana is saying, but additionally, the CGM can be invaluable to help monitor more frequently and guide trends. But we need to be aware that there can be interfering substances involved as well. And so we still, in a lot of situations, depend on the blood glucose value. And it's the reason that even individuals using CGM at school should have those additional blood glucose monitor supplies on hand at the site of the activity.
And we have one last question. What are the benefits of CGM for athletes?
I think we've discussed many benefits of CGM throughout this presentation today. The convenience of the data, the ability to remotely monitor the additional trend information, the communication with some of the pump systems for automated insulin delivery. Those are just a few. In the medical community, the CGM is a standard of care therapy for individuals with type 1 diabetes and for any using insulin therapy. And it's something even in pediatrics from day one, we're recommending as soon as possible. Having said that, also within our standard of care recommendations, it's important that we individualize therapy, and the student, the athlete, the family, the decision is ultimately up to them. And sometimes, whether it be access or cost prohibitive, there are personal decisions as well that lend them to perhaps choose not to use a CGM, and we need to respect that choice and just be sure that they have the most current information and detailed options so that they can select what option is needed for their family.
Yep, I agree. I mean, I think most students are going to choose to use CGM because not only all those benefits that Rebecca just said, but also like burden and quality of life that can really help help these kids with diabetes. In retrospective data, like we get a lot of good data that we see, we can really identify patterns and trends that are happening to keep them, you know, healthy and safe. So I think there are lots of good benefits, but it does come down to access and individualization and choice for a lot of these athletes.
That concludes our questions.
Okay, great. Well, thank you all so much.
I appreciate it.
Again, the recording will be available so that you can rewatch and look at some of the detailed information at your leisure. We thank you all for your participation.